Hi, it's Dr. Noni reviewing the literature again from my new studio. Let's review this interesting article about procalcitonin, a marker that I use daily in the ICU. The title of the paper is Reassessing Procalcitonin-Guided Antibiotic Therapy in Critically Ill Patients with Sepsis, Lessons from the ADAPT Sepsis Trial. The optimization of antimicrobial duration in the intensive care unit remains a significant challenge, balancing the necessity of clinical cure against the deleterious effects of antimicrobial collateral damage, namely resistance, microbiome disruption, and C. difficile infection. While historical data from trials such as ProRata and SAPS suggested that procalcitonin-guided algorithms could safely reduce antibiotic exposure, these studies were often hampered by open-label designs and inconsistent adherence to stopping protocols. Enter the ADAPT Sepsis Trial, the largest multi-center randomized controlled trial to date, which enrolled over 2,700 critically ill patients across the United Kingdom. Unlike its predecessors, ADAPT Sepsis utilized a concealed intervention and a head-to-head comparison with C-reactive protein to determine if biomarker-guided care truly offers a marginal benefit over high-quality standard of care stewardship. The biochemical rationale for procalcitonin lies in its rapid induction, rising within 2 to 4 hours of bacterial insult, and its subsequent rapid decay as infection resolves. In ADAPT Sepsis, a PCT-guided strategy using a discontinuation threshold of less than 0.25 micrograms per liter, or a baseline decline of 80%, resulted in a statistically significant reduction in antibiotic duration. Specifically, patients in the PCT arm saw a mean reduction of approximately 1 day compared to standard care. Crucially, C-reactive protein, or CRP, failed to show any significant reduction in antibiotic exposure, likely due to its more sluggish kinetic profile. However, the trial also revealed persistent implementation gaps. Despite strong stop recommendations being generated at a mean of 3.5 days, the actual mean duration of therapy was 7 days. This lag underscores a trust deficit in biomarker reliability, where clinicians remain reluctant to discontinue therapy in the face of perceived clinical instability, even when biochemical markers suggest resolution of the bacterial threat. For the practicing intensivist and infectious disease consultant, there are 3 primary take-home points from the ADAPT Sepsis data. First, procalcitonin is superior to CRP for guiding the discontinuation of antibiotics in sepsis. Its faster kinetics provide a more accurate real-time reflection of the resolution of the systemic inflammatory response. Second, the absolute benefit of PCT may be narrowing. As the standard of care moves toward fixed, shorter duration therapies, such as the 7-day course validated by the BALANCE trial, the marginal utility of a biomarker to save a single day of therapy must be weighed against the cost of serial testing. Third, the future of procalcitonin may lie in the emergency department rather than the ICU. Using PCT for early risk stratification and the delabeling of non-infectious sepsis mimickers may offer a higher diagnostic yield than using it solely for duration management in established cases. In summary, ADAPT Sepsis confirms that procalcitonin-guided discontinuation is safe and effective, but its successful implementation requires more than just data. It requires embedding these markers into a multifaceted, trust-based antimicrobial stewardship framework.